Hi students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we are going to discuss about the most important condition in gynecology. Okay, so it's all about the Polycystic Ovarian Syndrome. So PCOS is one such important topic without which you can't attend any examination in Obs and Gyne, right? So this is also the most important metabolic disorder which you need to learn because nowadays in this century, in this particular decade, right, we are seeing so much of cases in all the adolescent age group female. The most common cause of anovulation is PCOS. So most cases are PCOS in the gyne OPD. So for that reason also, as clinician, it is important for us to learn about this topic. Okay, so before starting with this topic, let me clear a controversy which is arising. So polycystic ovarian syndrome is also known as polycystic ovarian disorder, right? PCOD and PCOS are same. Polycystic ovarian syndrome is also the same and polycystic ovarian disorder is also the same. So PCOS and PCOD are the same term. Is that clear? Okay. So let's begin with the topic. So polycystic ovarian syndrome is also known as Steen-Leventhal syndrome. It is also called as Steen-Leventhal syndrome. So it is actually named after the American gynecologist who termed this term as PCOS because he was the one who identified this condition and he coined this term as PCOS in 1935. So PCOS is named after Mr. Steen-Leventhal. So it is given the name as Steen-Leventhal syndrome. Is that clear? Okay. And now, as I said earlier, PCOS is the most common cause of anovulation in females. What is anovulation? What is ovulation? Ovulation is the process where the ovum is getting matured and released during the 14th day of the menstrual cycle. And ovulation means the opposite to ovulation, where the process of ovulation is not happening in the menstrual cycle. So if ovulation is not going to happen in a menstrual cycle, then definitely there will be no release of mature ovum, there will be no corpus luteum and no progesterone. Because of decreased amount of progesterone and because of the absence of progesterone withdrawal, the patient is never going to experience any menstruation. So the most common cause of anovulation in females is PCOS. So most commonly, the adolescent age group females, they will come to the OPD with complaints of amenorrhea. So when you do the particular investigations in such females and you group the females according to the symptoms existing in her, you will come to a conclusion of this polycystic ovarian syndrome. Is that clear? Yes. So the most common cause of anovulation in females is PCOS. Now, apart from that, the most common cause of hirsutism in females is also polycystic ovarian syndrome. So before discussing about hirsutism, we will just learn about what is the main problem which is happening in PCOS. Only then you will be able to learn what is hirsutism. So as of now, just remember, PCOS is also called as Steen-Leventhal syndrome, which is named after the American gynecologist who coined this term, and PCOS is the most common cause of anovulation in females and it is the most common cause of hirsutism in females as well. And then it is the most common endocrinal disorder in female. Is that clear? It is the most common endocrinal disorder in female as well. Okay. So as the name suggests that polycystic ovarian syndrome, so definitely the problem, the pathology here in this syndrome is actually the ovary. So the problem is mainly with the ovary. So now what is the problem? The problem is that the ovary is going to produce increased amount of androgens. Now you may have the doubt that if androgens is produced in females, yes, androgens are produced in females as well. Similar to males, androgens are also produced in females, but they are produced in only little amount. They are not produced in an amount which is equivalent to a male. So in females, androgens are produced, but the production of androgen is comparatively lesser than the males. Is that clear? Okay. But the main problem in PCOS is that the ovary is going to produce increased amount of androgens. So now you may ask how ovary is going to produce increased amount of androgens. We all know that the luteinizing hormone has to act on the theca cell of the ovary in order to produce androgen. So basically we have two important hormones which are being released from the pituitary, to be even more specific from the anterior pituitary, and those are the follicular stimulating hormone and the luteinizing hormone, FSH and LH. FSH acts on the granulosa cells of the ovary to produce estrogen. Similarly, LH acts on the theca cells of the ovary to produce androgens. So basically, androgens are produced from which group of cells in the ovary? It is produced from the theca cells of the ovary. And where is the stimulus coming from? The stimulus is actually coming from the luteinizing hormone. The luteinizing hormone is going to act on the theca cells of the ovary to produce androgens. So this is a normal phenomenon which happens. But in PCOS, there is increased amount of androgen being produced from the theca cells of the ovary. So what do you mean? It means that the luteinizing hormone is actually increased in patients of PCOS. So only when the luteinizing hormone is increased in patients of PCOS, the increased amount of luteinizing hormone can act on the theca cells of the ovary, and therefore increased amount of androgens will be produced in such group of females. Right? Okay. Now, so let's discuss about androgens in PCOS. Okay. So what is the normal androgen levels in females? So the normal androgen levels in females is less than 70 nanogram per ml. Please remember this important point. The normal androgen levels in females is less than 70 nanogram per ml. But in patients of polycystic ovarian syndrome, the androgen levels were somewhere between 70 to 200 nanogram per ml. Somewhere between 70 to 200 nanogram per ml. Normally in females, the levels are less than 70, but in patients of PCOS, I told you there is increased amount of androgens. So in patients of PCOS, the androgen levels are somewhere between 70 to 200 nanogram per ml. Okay. Let's say for an example that in a female, you're going to check the amount of androgens in her. If the report comes that the amount of androgens are more than 200 nanogram per ml in a female, it means that the problem is not with the ovary. The problem is not polycystic ovarian syndrome, but it is a congenital condition where the condition is congenital adrenal hyperplasia. Because of hyperplasia of the adrenal gland, there is increased amount of androgen being released from the adrenals. Is that clear? See, let me make it very clear. The normal androgen levels in female is less than 70. But in PCOS patient, it is between 70 to 200. But if in a female, if the androgen levels are more than 200 nanogram per ml, it means that the problem is not with the ovary. It is actually a congenital condition where the adrenal gland is hyperplasia. It's in a condition of hyperplasia. So because of the hyperplasia of the adrenal gland, which is a congenital condition, so because of congenital adrenal hyperplasia, there is going to be increased amount of androgens being released from the adrenal gland. So because of this congenital adrenal hyperplasia only, there is increased amount of androgens in that female, which is more than 200 nanogram per ml. So in a patient who is complaining of amenorrhea to you, if you check the levels of androgens in her, if it is going to be more than 200 nanogram per ml, PCOS can be ruled out in that patient. So you can easily rule out PCOS in this patient, because we know that in patients of PCOS, the levels of androgen is only between 70 to 200. If it is going to be more than 200, then the probable cause could be congenital adrenal hyperplasia. Is that clear? Okay. But then you also need to remember that in patients of PCOS, androgens are not only produced from the theca cells of the ovary, but androgens are also produced by the adrenal gland. So what is the androgen which is being produced by the adrenal gland in patients of PCOS? So those are the dihydroepiandrosterone sulfate. Those are the dihydroepiandrosterone sulfate, DHEAS. So in patients of PCOS, androgens are not only produced from the theca cells of ovary, but also been produced from the adrenal gland, which is DHEAS. So therefore, the levels of DHEAS will also be increased in patients of PCOS. Is that clear? Androgens will be increased in patients of PCOS. Similarly, dihydroepiandrosterone sulfate will also be increased in patients of PCOS. Right? Okay. So now we will go inside the features of polycystic ovarian syndrome. So I have made simple flowcharts for you so that this topic is going to be very easy for you to remember as well. Okay. So the main pathology is that the androgen levels were increased in patients of PCOS. So if the androgens are increased in females, what will be the clinical manifestation? So you can actually divide this into clinical manifestation, and biochemical analysis. So clinically, through symptomatic or through signs, you are going to observe certain features in that female. So clinically, you will be able to see hirsutism. So now we'll discuss about hirsutism. What is hirsutism? Hirsutism is a condition where there will be growth of hair in male pattern in females. So we all know that because of increase in testosterone in males, there is going to be coarse in nature hair being present in females, such as the beard, the mustache and everything, right? Similar to the male pattern, because of increased in androgen levels in females, there is going to be growth of coarse hair in male pattern being present in patients of PCOS. So where are these hair is going to be present? It is going to be present in the upper lip as mustache, over the chin, over the chest and the upper back, the shoulder and everywhere. So similar to a male pattern, the growth of hair will be present in a female with PCOS. So that is called as hirsutism. Is that clear? So increased androgens will present clinically as hirsutism. So there is a scoring which has been used in hirsutism, and that scoring is Ferryman-Galway scoring. That scoring is Ferryman-Galway score. So if the score is going to be more than equal to 8, it is a case of hirsutism. The female is a case of hirsutism if the Ferryman-Galway score is going to be more than equal to 8. But if the Ferryman-Galway score is going to be more than equal to 15, then that female is a case of severe hirsutism. So there is a difference between hirsutism and severe hirsutism. More than equal to 8, she is a case of hirsutism. But if it is going to be more than equal to 15, then she is a case of severe hirsutism. So depending upon the feature, the treatment will also vary. The treatment also needs to be very the treatment also needs to be very aggressive than the simple hirsutism. So there is actually a difference between the simple hirsutism and severe hirsutism. Simple hirsutism is where there is growth of coarse hair similar to male pattern being present in patients with PCOS. But severe hirsutism means there may be even more clinical manifestation, may be even more severe in that female, right? Depending upon the Ferryman-Galway score, the treatment approach will also vary. So the treatment will actually be divided into mild, moderate and severe, and depending upon the symptom complex which has been present in that patient, the treatment will be decided upon. So increase in androgens can be of two kinds. Either it can be a clinical manifestation such as hirsutism, or it could be through the biochemical analysis where you are going to test the patient for the androgen levels. So if the androgen level is going to be increased in that female between 70 to 200 nanogram per ml, then she is a case of polycystic ovarian syndrome. So clinically you can see it as hirsutism. Biochemically, if you do the blood analysis, you can see the increased amount of androgen levels in patients of polycystic ovarian syndrome. Right? Very good. Now, I told you in patients of PCOS, the main problem is that the ovary is producing increased amount of androgens. So because of this increased amount of androgens, what is actually going to happen is that we know that the ovary is going to have multiple ovarian follicles. Those are the immature ovarian follicles which are present in the ovary. So increased amount of androgen is actually toxic to the ovarian follicles. Since increased amount of androgen is toxic to the ovarian follicle, all the ovarian follicles which are present in the ovaries are going to be arrested in growth. We all know that the ovarian follicle has to mature in the menstrual cycle, and only then it gets released as a mature ovum. But because of the presence of increased androgens in patients of PCOS, this androgens which are increased in amount is actually toxic to the ovarian follicles. So therefore the ovarian follicles are going to be arrested in growth. So since the ovarian follicles are arrested in growth, if you are going to do, suppose if you are going to do ultrasound in patients of PCOS, you may or you may not be able to see multiple immature ovarian follicles in the ovary. Right? When you see the ovary in ultrasound, there can be multiple immature ovarian follicles. But it is not necessary that when you do ultrasound in a patient of PCOS, definitely the ultrasound has to show multiple immature ovarian follicles. It is not like that. The ovary may be normal in a patient of PCOS as well. So it is not definite that the ovary has to contain multiple immature ovarian follicle to define her as a case of PCOS. It is not like that. So the ultrasound it may show or it may not show multiple immature ovarian follicle. Now what we are saying is that if you do ultrasound in a patient of PCOS, you may or you may not be able to see these immature ovarian follicles. Because why it is immature ovarian follicle? Because the ovarian follicles are actually arrested in growth because of the folliculotoxic nature of the androgens. Is that clear? Yes. So now, since there are multiple immature ovarian follicles in the ovary, we all know that the immature ovarian follicles are going to secrete anti-Mullerian hormone. Since there are multiple immature ovarian follicles, therefore the levels of anti-Mullerian hormone are going to be increased, because all these antral follicles, all these immature follicles are going to produce anti-Mullerian hormone. Since they are multiple and they are immature in nature, there is going to be increase in anti-Mullerian hormone levels. So the AMH levels will be increased. Is that clear? Yes. So now we're moving on to the third feature. So the first feature was increase in amount of androgens, which can be seen clinically as hirsutism or biochemically as increased levels of androgen between 70 to 200. The second point is that the androgens which are increased are folliculotoxic in nature. Because they are folliculotoxic in nature, the follicles are going to be arrested in growth. In ultrasound, you may or you may not be able to see multiple immature follicles. Since there are multiple immature follicles, there are increased in amount of anti-Mullerian hormone which are produced by the antral follicles. Now the third feature is that I told you LH acts on Tika cells to produce androgens. But in patients of PCOS, the main problem is that LH is going to be increased. But this increase in LH is throughout the menstrual cycle. Is that clear? LH is increased, but the increase in LH is throughout the menstrual cycle of the female. We all know that just before the ovulation, LH surge has to happen. About 24 to 36 hours before the ovulation, LH surge has to happen. Only if LH surge is going to happen, then the ovulation trigger will happen, and then the ovulation is going to happen. If the LH surge is not going to happen, definitely ovulation is not going to happen. But in patients of PCOS, the LH levels are increased throughout the menstrual cycle. So they are constantly increased throughout the menstrual cycle. Let me show a diagrammatic representation. See, this is the LH surge and this is the ovulation. So initially it is see, as you can see here, the LH levels are initially stable, and then it has a surge. Following the surge, after 24 to 36 hours, ovulation is going to happen. But in patients of PCOS, right, if this is the base, the levels of LH are increased throughout the cycle. So throughout the cycle, it is constantly increased throughout the cycle. There is absence of this LH surge. Throughout the cycle, the levels of LH is actually increased. So because of the absence of LH surge, which has to happen 24 to 36 hours before the ovulation, since there is no LH surge, there is going to be no ovulation. Why there is no LH surge? Because in patients of PCOS, the LH levels are increased throughout the cycle. LH levels are increased, but LH level is not getting surged. So since it is increased throughout the cycle, no LH surge. In the absence of LH surge, ovulation will never happen. So it is a case of anovulation. Since there is no ovulation, there is no release of mature ovum. There is no formation of corpus luteum. If there is going to be no corpus luteum, there is going to be no progesterone. If there is going to be decreased amount of progesterone, there can never be progesterone withdrawal will never happen, because we all know that only if progesterone withdrawal is going to happen suddenly, that the uterus will lack its support and the menstruation is going to happen. Since there is no progesterone withdrawal, so there is going to be no menstruation, which is called as amenorrhea, or decrease in amount of blood flow, which is called as oligomenorrhea. So since there is no ovulation, which is anovulation, the patient will complain of infertility. So if someone asks you why the patient complains of infertility, why a patient of PCOS complains of infertility, there is a difference between these. If a patient of PCOS complains with infertility to you, the most common reason is what? Because in patients of PCOS, there is no ovulation at all. She is a case of anovulation. Since there is no ovulation, therefore she will present to you as a case of infertility. Right? And I have to tell you something. The most easily treatable form of infertility is anovulation. And in patients of PCOS, it is the most easily treatable form of infertility in females. So if you take the causes of infertility in a female, the most easily treatable form is this PCOS, because in PCOS the problem is anovulation. So if you're going to introduce some drugs to the female which are probably the ovulation inducing agents, the patient is actually going to ovulate and there is going to be release of mature follicles, and then the patient can get conceived as well. But then the problem is that since there is no progesterone in patients of PCOS, even if the patient is going to conceive after doing the ovulation inducing procedures, there could be increased chances of abortion even if the patient conceives. There are chances of abortion if the patient conceives. Is that clear for you? See, in patients of PCOS, the problem is anovulation. So, anovulation is the most easily treatable form of infertility. Why? You are going to use ovulation inducing drugs. So, what are the ovulation inducing drugs you know? Those are the letrozole, clomiphene citrate, and etc. In patients of PCOS, the anovulation could be best treated with the drug letrozole. So what is the drug of choice for treatment of infertility in patients of PCOS? It is actually letrozole followed by clomiphene citrate. So just check in your question whether letrozole or clomiphene citrate is given. If letrozole is given, letrozole should be the answer. If letrozole is not given and clomiphene citrate is given, then clomiphene citrate is going to be the answer. So the most common is letrozole followed by clomiphene citrate. So if you're going to introduce ovulation inducing drugs to that female, therefore the patient is going to hyperovulate and there is going to be release of mature ovum and then she can get conceived. But then what I'm saying you is that even if the patient is going to be conceived following the ovulation inducing drugs, there could be increased chances of abortion in that female. Why? Because is that in patients of PCOS, there is no corpus luteal formation and there is decreased amount of progesterone. If there is going to be decreased amount of progesterone in a female who is pregnant, then there could be increased chances of abortion in that female. So decreased amount of progesterone in a patient of PCOS who has conceived, there are increased chances of abortion even if the patient is going to conceive. I'm not telling that every pregnancy has to end up in abortion in patients of PCOS, but there are chances of abortion in patients of PCOS who is going to conceive following this ovulation inducing drugs. Is that clear? Yes. Now you may have the doubt that what is ovulation inducing drugs? So ovulation inducing drugs are nothing but, see, we know that ovulation is the process where mature ovum is going to be released from the ovary, right? But in patients of PCOS, there is anovulation where the mature ovum is not released from the ovary. But if you are going to artificially induce this process with the help of some drugs such as the letrozole and clomiphene citrate, it is going to result in release of mature ovum from the ovary. So mature ovum will be released from the ovary, and simultaneously if the patient is going to have coitus with her partner, then this mature ovum will get fertilized and she can conceive, right? So this is the actual procedure of this ovulation inducing drugs. So after she conceives, I'm saying that because of decreased levels of progesterone in patients of PCOS, she may end up in abortion as well, right? Okay, so now we are just summing up. So in patients of PCOS, what are the hormones which are going to be normal and what are those hormones which are going to be decreased and what are those hormones which are going to be increased? So in patients of PCOS, FSH levels, that is the follicular stimulating hormone, is going to be normal, because our problem here is mainly with the LH and androgens. Increase LH, increase androgens, but FSH has nothing to do with PCOS. So FSH is normal. What about LH? LH is increased. LH increase acts on Zika cells and produced increased amount of androgens. So the levels of androgens are actually increased, which is between 70 to 200. So Zika cells produce androgens and adrenals produce dihydroepiandrosterone sulfate. Is that clear? Yes. And what about the estrogen? So when we talk about the estrogen, in thin females, the estrogen is going to be normal. But in obese females, the estrogen is going to be increased. Why? Because is that the androgens which are present in the adipose tissue of obese female, in obese female the amount of adipose tissue is going to be increased. So the androgens which are present in the adipose tissue are going to get converted to estrogen with the help of the enzyme aromatase. So in the adipose tissue, the androgens are going to get converted into estrogen. Most commonly it is the estrone E1 with the help of the enzyme aromatase. So since the levels of estrogen are increased in obese PCOS patient, the patient can complain of increased amount of heavy menstrual bleeding and the cycles could be irregular. So she can complain of heavy menstrual bleeding and irregular cycles as well, which is combination it is called as menometrorrhagia. Menometrorrhagia. Metrorrhagia means irregular, meno means increased. So increased amount of blood flow which is irregular in nature cycles or menometrorrhagia happens in patients of obese PCOS patient because the levels of E1 are increased in patients of obese PCOS patient because the androgens get converted in the adipose tissue to estrogen with the help of the enzyme aromatase. Is that clear? Yes, so FSH normal, LH increased, androgen increased, estrogen in thin females it is normal, in obese female it is increased. Okay, so next point. Since there is no ovulation in PCOS, there is going to be decreased amount of progesterone as well. Right? No ovulation in PCOS, there is going to be decreased levels of progesterone. Just a small correction, right? We have discussed about estrogen already. So now, since there is no ovulation in PCOS, no corpus luteum, since there is no corpus luteal formation, no progesterone or decreased levels of progesterone. Therefore, in patients of PCOS, the progesterone levels are decreased. Is that clear? Yes. Okay. So what about the androgens? I told androgens are increased. So now we say that increased amount of androgen is actually going to inhibit the sex hormone binding globulin production by the liver. Increased amount of androgen is going to inhibit sex hormone binding globulin production by the liver. Therefore, the sex hormone binding globulin is going to be decreased in patients of PCOS patient because in patients of PCOS androgen levels are increased. So this increased androgen level is actually going to inhibit the sex hormone binding globulin production by the liver. So sex hormone binding globulin is decreased in patients of PCOS. Fine? Yes. Next, in patients of PCOS, there is increased low density lipoprotein and decreased high density lipoprotein. What is low density lipoprotein? LDL. LDL is also known as the bad cholesterol. HDL, which is high density lipoprotein, is also called as the good cholesterol. In patients of PCOS, there is going to be increased amount of LDL and decrease in amount of the HDL, which is the good cholesterol. So since the good cholesterol is decreased and the bad cholesterol is increased, as a long-term consequence, there could be dyslipidemia where there could be excess amount of cholesterol being present in this patient. So since there is dyslipidemia is a risk factor for coronary artery disease. So later on, the patient can have coronary artery disease as a long-term consequence as well. Is that clear? Yes. And then the most important feature is that in patients of PCOS, there is insulin resistance. What is insulin resistance? The patient is actually resistant to insulin. So there is increased amount of insulin being produced in that patient. So when there is going to be increased amount of insulin produced in a patient of PCOS, therefore increased amount of insulin will also lead to obesity in that patient as well. So the patient is going to be obese and there is going to be insulin resistance. So the most typical feature of insulin resistance is acanthosis nigricans. What is acanthosis nigricans? Appearance of velvety skin, pigmented velvety skin in the nape of the neck. So you might see around the neck a pigmented velvety skin, a darkly pigmented velvety skin appearance in the neck. So this is a feature of insulin resistance. So acanthosis nigricans is a feature of insulin resistance. As a long-term sequence, this insulin resistance will eventually lead to type 2 diabetes mellitus. So the patient will develop diabetes mellitus. Right? Okay. So now we have dealt about which are the hormones which are going to be normal and increased and decreased in patients of PCOS. So now as a grouping, What are the hormones which are normal in patients of PCOS? Those are the follicular stimulating hormone, FSH is normal. In thin females, estrogen is normal. In obese female, E1 is increased, right? And serum prolactin level is normal in patients of PCOS. FSH, thin females, estrogen and prolactin is normal in patients of polycystic ovarian syndrome. Is that clear? So, as I have divided this PCOS topic into 3 modules, now I think it will be enough for you to learn this much in this particular module. So let's meet in the next module, where we'll be dealing with some important criteria in patients of PCOS and what will be the long-term complications and how you need to actually manage the patients of PCOS according to symptoms, right? So that will be dealt in the subsequent modules. I hope that I've been very crisp and concise with respect to this topic, and please keep revising this topic as it is very important for you in your examination. And if you have any queries, please write to us. We will just reach out to you as early as been possible. And without fail, just subscribe to this Mackler YouTube handle so that you will get the